Okay. Next. Colostomy, ileostomy, ostomies of any sort. Any ostomy needs a bowel prep. Any ostomy needs a bowel prep because this is a surgical procedure. You're going in my gut and all GI is dirty and you knew that. So all ostomies need a bowel prep. When the patient comes out into recovery, the stoma should be red, beefy, moist, and shiny, and yes, you need to know that.
Bleeding is okay.
Yeah, post-op, yeah.
I got that question wrong.
Oh, on your real test?
No, on that question.
Oh, yeah, when you first come out of the OR, oh yeah, you just cut me. Immediately post-op. Immediately post, that's it, right there. Yep. And even post-op day 1, you're not going to freak out if there's a little spotting. Okay?
You said red, beefy.
I wrote it. What are you doing? Stay with me. What a child. You better help your sister over there, girl. You know she got issues. Okay. Now, I mean, really, this was so fun about this lecture. It's a lot of highlighting. But the capital letters are, let's just say, important. Okay. Now, bold and capital. Very important. Now, you can see what I wrote. Limit the gassy foods. If the patient is concerned about odor, which if they're smart, they should be, then the key to that is to limit the gassy foods. If you look at some of the foods we have, there's a lot of them missing. So you're going to add cauliflower. It is? Oh, I did. I added it. Okay, onions I put on there. Oh, I have an updated copy. Okay, good. Do you have cheese? Yeah, I did update it. Okay, cool. I update so much shit, I don't know. But anyway, those are the gassy foods. Now, the stoma will not work for how long? So here's what you got to know about that comment. You do not care if the colostomy bag is empty day 3. I just said it ain't working. Do you see how that translated? I'm going to try that again. I wrote that it does not work for 48 to 72 hours. Therefore, you did not freak out if day 3 the colostomy bag is empty because it's not working yet. You didn't have spaghetti waiting for the patient after surgery, did you? So what's supposed to be in the bag? You ain't gave the patient nothing to eat, hell. You had them NPO beforehand. You cleaned their bowel right beforehand. Right after, you wasn't giving them much. Clear liquids at best. Are you feeling me yet for why this bag may not have anything in it? Okay? You got to know that. Low residue diet, no seeds. I don't know if I wrote it anywhere, but help me out if I didn't. I should have wrote chew food thoroughly. Chew food thoroughly. We don't need you scarfing down a meal at the red light. Chew your food thoroughly, okay? Now, the other part is you see the foods that will decrease odor. You need to know that. The cranberry juice, bananas, okay? It's all about the diet. Remember with the colostomy, the patient does not have to wear the bag. So that's a big deal. And a lot of people don't. And let's make sure we know how that happens. If you look at the colostomy section, you want to remember this bag is on the left side. It is formed stool, and the bag is unnecessary after bowel training. This colostomy can also be temporary, just until the bowel heals. All that's written for you already. Now, so how do I do bowel training? Okay, you have to really make sure you understand this. I have a colostomy. I'm not trying to wear this bag and have my life turned upside down. I have to go through training my bowel to go and poop every single day, exact same time, empty it, boom, done with the bag. So when you look at the training, it is done with an irrigation the same time every day to stimulate peristalsis. If the patient is cramping during this training or irrigation, stop it. I wrote all this already for you. Restart it if the cramps stop at a slower rate. It takes about 6 to 8 weeks to work. These are big deals right here. Don't insert the cone more than 3 inches. Okay? So that's a big deal. Change the bag in everybody every week to 10 days. The number one cause of skin irritation is, and I would write this down, I would put the number one cause of skin irritation is an ill-fitting appliance. And yes, you do need that ill-fitting appliance. In other words, beloved, it don't fit. They didn't cut it right, they either cut it too big, too small, or something. But it does not fit. You need it cut 1/8 inch greater than the stoma. No laxatives ever. Teach the patient to empty the bag before intercourse. Okay, so it's a lot of stuff you have to remember. Where it says ileostomy, this is completely different from a colostomy. And one of the things I find is very shocking is that the beloved student doesn't know what happened. During an ileostomy, you will have to know what happened. We remove the entire large intestine. You got to know that. When we do an ileostomy, it's permanent because we took out your large intestine. The bag, this bag, is on the right side because that's where your ileum is, on that side. Okay? So the ileum or ileostomy is going to be on the right side. We tell you to remember it's diarrhea in a bag. If you remember that it's diarrhea in the bag, you can see how there'd be no way on God's green earth you wouldn't wear this bag. You have to wear this bag. You do not irrigate. And because it's diarrhea in the bag, everything that happens with diarrhea happens with this patient. They're easily dehydrated. They easily have skin irritation because with diarrhea, that's what you get. Easily dehydrated, easily skin irritated. Okay? All right, so this again, I wrote chew food thoroughly. And oh my God, look at that. Big capital letters, bold print. Empty this bag every 3 to 4 hours or when it's 1/3 full. I don't care which one. You got to know both. Okay? Empty every 3 to 4 hours or when it's 1/3 full. Okay? So if you picture what I wrote above that probably should have went with ileostomy, look what I wrote above, and I probably should have put that with the ileostomy. It says normal stool output 1,000 cc's in 24 hours. Picture that in that bag. It's not that big, is it, y'all? Can you see where an ileostomy needs to be emptied very frequently? Because if you got liquid stool up to 1,000 milligrams, you're going to bust that bag, and you're going to perforate the ileum. You got to empty it, okay? All right.
So you said that goes with the ileostomy?
It does, even though it's technically true for both.
Okay.
This just helps you understand why it's so critical to empty it. Coke's pouch is a little bit different. Get this. This is what we did with this one. We put the bag right here inside of you. We literally put the bag inside of you. So it's called a continent ileostomy. There's no appliance on the outside. There's no bag on the outside. And you can drain it when you want to drain it. The only problem with this is you can see with this, there's an even bigger complication if you didn't empty it. This for sure is a bigger risk of perforation because it's inside of you. It's called Koch's pouch. Okay, it's a continent ileostomy. The membrane, we use a membrane in a bag, we put it inside of you, and you just take a catheter and empty it. You just empty your own pouch, but nobody sees that. Okay. Now, I put ileoconduit there just so you knew not to confuse it. I could have put it with the urine stuff, but I put it with the bowel stuff because nurses confuse this. You remember how I said an ileostomy and a colostomy don't have to work right away? Okay, that's not true for ileoconduit. It has to work immediately. Why? Because we produce urine constantly. And ileoconduit is a urine bag, okay? It's called urinary diversion, okay? So imagine if you and I, all of us, went to the bathroom right now. We took a little field trip. We said, on your mark, get set, go, pee. And y'all emptied all your bladders at the same time. When we come back in here and sit down, we already got urine in our bladder. We have to remember that when we talk about this patient, we know that this has to work immediately post-op. In the OR, there better be urine in this bag. That's important. Hint, hint.